Thank you very much. It's a pleasure to be here with all of you today and talking about something that is important to me and others who sit in my chair. The reason is that we're all under a lot of financial challenges as payers. And understand it's about balancing for us access and affordability while driving innovation. So when we see more expensive drugs come out that have questionable data, it puts us kind of in a difficult situation where it creates an expectation among those who we cover that the drugs will be available, yet sometimes the evidence is broad or unclear, et cetera, and the pricing is uncertain. So let me put this into context here. Why are we so focused on drugs more so than we were a couple of years ago as payers? Couple of points. First of all, the unit cost increases are inexplicable to us, particularly for new-to-market drugs. We've seen cases where we've mapped out categories like anti-TNFs, and they go up in staircase fashion. In many cases, again, for drugs that are not new, and it's we don't understand why. We already think that they are priced fairly. Again, if we didn't have to go back and look at how we pay for these, it might not be an issue. As a payer and a not-for-profit, I'll add the last 3 years were very not-for-profit, but it's also a good thing to break even. Although we can dip into our reserves for a while. But I mean, it does speak to the culture of our organization. And I always remind our medical directors, our policy people, when you're in a tough situation, think about what would you want available to a member of your family. And that's kind of the litmus test to me. But there's a lack of transparency around pricing. In many cases, we really don't get why drugs are priced the way they are. And it seems to be what the market will bear. And I think the extent to which state legislatures and the U.S. Senate, et cetera, are calling in executives and asking questions or sponsoring transparency bills speaks to that. Lack of planning and surprises. We could talk for that about 20 minutes, but let's just say that when you have a new drug like Hep C treatment, where the expense, the product of the utilization times unit cost exceeds 2% of your budget, and you're not for profit, which is trying to achieve a 1% margin, it creates problems. We realize that other developed countries pay a lot less than we do, and then we're under a lot of pressure from employers. So ultimately, most of our customers are employers, although we have about 10% exchange, and I meet with them regularly. And just the past year, they're all asking about drugs. Show us why you covered these drugs and not those drugs. They all want the right therapies available to their employees, but they're really pretty angry about the premium increases they're seeing. A couple of metrics here, just to really frame this. We estimate that about a third of the premium increases we've requested from the regulators are attributed to pharmaceuticals. We also looked at the percent spent on drugs. And again, there's a lot of different data out there, and I think it depends what you use as your data set, what's in the denominator. This is from the perspective of a commercial payer that doesn't cover things like long-term care. But in 2016, and frankly in 2015 as well, we spent $1 out of every $4 spent on healthcare. Of the $3 billion we spent was spent on drugs. That's on an allowed basis, which is insurance geek talk for what was spent regardless of whether you paid for it or the insurer. It includes both the pharmacy benefit drugs as well as the medical benefit, and that latter group is about a fifth of the total spend. And we actually exclude drugs administered in the hospital, which is a material number, but we don't know what it is because we tend to pay hospitals through DRGs and other mechanisms where we don't actually see the line items. The other thing that's really interesting is we looked at what percent of the spend is covered by the individual. And it's been dropping steadily, as you can see there. I thought it had leveled off in about 2015, and then we saw it drop further to about 21.5% of every dollar spent on drugs in 2016. And I think the reasons for that are we're seeing a lot of high-cost drugs, and because we generally have maximums through out-of-pocket maximums or even plan design, we try to protect individuals because in general, I think it's pretty easy to argue that if people are on medications prescribed by their physicians, you want them to take them, and cost should not be a barrier. And then final number, I watched the specialty pharmacy numbers very carefully. That's going up 20% year over year in terms of the spend. And it's hard to argue it's sustainable because, again, either you're paying for it or we're all paying for it. And if you look at the numbers about what's paid by individuals, I think we can argue that we're all paying for it. Again, none of these are numbers, they're objective, they're not good nor bad, they're numbers. And one could argue, probably very eloquently and perhaps correctly, maybe the percent spent on pharmaceuticals should be 30% or more. And if you show me more drugs that keep people out of the hospital, extend life, improve chronic disease, that would be desirable. If you show me more drugs like Jublia, which cost $6,000 and treat toenail fungus, perhaps not so much. So that's some of the challenges we're dealing with. So getting to the crux of this, why are clinical trials not real-world evidence? And this is something we deal with and struggle with. I chair a P&T committee, which meets regularly, and the data that we get for new drugs, it's useful, but it's kind of like those ads for cars. Here's the mileage, and then the fine print. Your mileage may vary in normal driving, and we kind of feel that way about it. And again, as I think everyone knows, but just to summarize, when you're doing a clinical trial, and fair disclosure, back earlier in my career, I actually was head of medical affairs for a small biotech company. The company did not do well, and I realized then that I wasn't smart enough to stay on the life sciences side, and I wound up doing some other things, so fortunately. So I was putting together clinical trials, and I realized you're looking for those investigators who do as much as possible of whatever that specific area is, whether academics, which were the majority, or some very busy private practices that saw a lot of patients with that diagnosis we're studying. And again, they see a large number of patients. This gets instantiated into how they practice medicine. They're fully compliant with all the protocols. They choose the patients carefully. And all the patients are very closely followed for data collection to make sure that they're adherent to understand, et cetera. And again, that's a best case scenario. Diagnostics offer additional challenges, and one of the big ones that's coming up is what we call clinical utility, which is in English the so what. So there are many tests. Oncotype DX would be an example of one that I think is generally agreed upon helps, and that assists physicians and patients in determining whether to pursue more aggressive treatment for breast cancer versus observing. And there are a slew of tests like that we're really interested in, that certainly I can understand why that would positively inform treatment decisions. Yet what we see in the real world, particularly where the physician may not be bought in and may have their own bias, which may or may not be driven by how they trained or what they're compensated for, et cetera, it doesn't always play out that way. And that's one of the reasons we are reluctant and question paying for some of those things. The other point, just to say, and again, people, I may not need to say it here, I need to mention this when I speak in Boston, where I flew down from. There's these things that when you kind of drive outside of Boston far enough, you come upon, they're called community hospitals and community practices. And some people in Massachusetts don't actually believe they exist in Eastern Mass, but they do. And people actually see patients for a living. They don't do research. They don't have time to read every journal. They may be seeing a patient on average every 15 minutes, which they would tell you isn't enough time. And so when there's something complicated and new that needs to be used a certain way, it doesn't always happen as it should. So again, we worry about what happens in those settings. And I think there's so much evidence out there that even for commonly accepted treatments, that there for hypertension, diabetes, nothing esoteric, that there's a lot of examples where evidence-based medicine is not followed. So you get these newer therapies, which are, again, very carefully selected and expensive, and we worry about that. And again, we worry because if we don't manage these carefully, we have to go raise premiums a lot. Again, the levers we have are premiums, deductible, and cost share, and frankly, everyone's pretty unhappy if we hit any of those. Challenges are increasing. The financial pressures, new drugs, CAR T, gene therapy, et cetera, those are very exciting. I'm personally an optimist. I think these will change lives, and we're going to want to cover these, but we're going to want to cover those in cases, again, where they're shown to be of value. So again, financial pressures are if only increasing. The regulators are not happy about approving premium increases, nor are employers. Individuals don't want to pay any more. So again, if it's either you or everyone, you run into some roadblocks there. I mentioned the pricing is arbitrary, and that really hasn't changed for the most part. We have seen some pharma companies recently go to entities like ICER proactively and voluntarily and say, assess the price effectiveness, the value of our drug. And I won't get into the methodology. They base it on about $150,000 for quality-adjusted life here, which seems like a fair metric. And so they come out with ranges as well as some other information, very useful to organizations like myself. And I would say there seems to be a grand bargain emerging where when companies do that and price it where ICER comes out at, there is a greater willingness to get out of the way and not try to restrict utilization. The other thing is that we're seeing some approvals of late. I don't know if the commissioner is still here, but got a few comments. But from the payer side, we're seeing some approvals, think Spinraza and Exondys and some of the others recently, which are causing a lot of heartburn for the payers. In some cases, the data is limited. You combine that with pricing, again, which is inexplicable, and add in variability in clinical response, and payers are understandably a little concerned. This actually arguably isn't good for other stakeholders as well. For sponsors, for the companies, it actually creates uncertainty. So in the past, most companies and other stakeholders kind of assumed that everything is covered to the label. And in many cases, if not most, that's the case. In some of the more recent cases where the perception is that the approvals were overly broad, payers have been reluctant, and there's much more variance than I've ever seen in terms of how different payers across the country are covering those. And again, more and more, I'm hearing that the question of public perception is entering into it, which to me is at the other end of the data spectrum. So I think we should be focused on clinical guidelines, on data, not on are people going to say mean things about us and protest if we cover or don't cover the drug. Should be about the evidence. On the other hand, the FDA has my sympathy, and as do the patients and families who have these conditions. Gets back to the question, what would you want if it were a member of your family? And I can certainly understand how even with limited evidence for a small percent of the population, there's hope there, and we shouldn't discount that. There's also the reality that I think many of us appreciate and don't talk a lot about is that for many conditions, we're never going to see what we would think of as a proper high quality randomized clinical trial of sufficient size, et cetera. In some cases, the conditions are just too rare to do that. In other cases, the time that it takes to generate what we would view as optimal data can be significant, and there are patients who are not getting treated in the meantime who might be benefiting. So there's an ethical question as well. So that is essentially the tightrope that we're walking and what we're trying to manage. And so in terms of opportunities, what can we do about this? So I want to offer a modest proposal, and I'm particularly thinking about these areas where there are new drugs for unmet need. Unmet need generally means very high cost, and the two tend to go hand in hand. And those are the cases where there is, again, understandable pressure to approve them because we want to provide access. So how do we balance the different factors here, access and affordability? How do we provide access to patients who need them while not bankrupting the system in the meantime, particularly looking at the pipeline of incredible treatments that are coming out there? So I want to stress we don't want it to kill innovation. And I'd be the first to acknowledge that those who are doing research and developing these new therapies and diagnostics, et cetera, there needs to be a reasonable rate of return commensurate with the risk, or they're not going to attract capital, and we're not going to see these amazing breakthroughs. So again, this is a nuanced discussion. So what can we do about this? Well, the first, and I'm using the word require in quotes because I know that the FDA is limited what it can actually require, would be to require manufacturers to enter into value-based agreements for reimbursement that are tied to the success of the drug. And we've done this. We've done, Harvard Pilgrim, my organization, has done about a dozen outcomes-based agreements. That's the good news. And they put some portion of reimbursement for the drug at risk, depending on whether it actually does what it's supposed to. The bad news, though, is that in each case, these 12 agreements, and we have a lot more that we're in discussions with, but with companies, in each case, they're for drugs where there's competition. For cases where the high cost, no competition, including some of those I've mentioned, the manufacturers have not felt the need or the pressure to enter in these kind of agreements. So I would argue that for high cost conditions where there's a variable response, or for other complex conditions like cancer where a drug may be worth it if someone survives for 2 years, but not for 3 months. We haven't had any success here yet, although we're having some very good collaborative discussions. So I could see that as a mechanism. Make it a heads you win, tails you don't lose value proposition for the payer. So if it works, gladly pay for it. If it doesn't, agree that it may be worth only a small percentage, somebody to cover the costs. Second, and again, use the word require here in quotes because I understand that there's limitations, but we want the manufacturers to submit data to an objective third party. And ICER, the Institute for Clinical and Economic Review, comes to mind. There doesn't have to be ICER, but I think they've just through their efforts and visibility and frankly transparency have come to occupy that position formally. But what we need is a third party so that in an outcomes-based agreement, if it works, the question is it worth 700,000, 300,000, $1 million? Well, I don't know. And again, we can debate that, and to have a third party that looks at methodology that has a transparent mechanism for coming up with an answer is very helpful. And the other thing I'll mention, and this comes up in meetings usually with people from NICE and European countries, is that they actually, their economists believe that a dollar spent on one thing is not a dollar spent on something else. We don't actually act that way. And when I look at the pipeline of drugs that we should and want to provide to our members, we need to think differently if we're going to make them available without bankrupting the system, or we're going to head for a crack up that nobody will like. So the other point here I'd make is that we should encourage, and this is something the FDA already does in virtually all cases where there's limited data set, encourage post-marketing data to be collected, and particularly when there are these value-based agreements where we're paying a lot of attention to the outcomes, I would argue that these de facto create real-world evidence. So we actually are in, for example, a negotiation with a diagnostics company where, again, we don't agree, we're not sure on the impact of their therapeutic, so they're willing to go out there at risk for whether this test actually does what they say it will. And in conjunction with our institute, which is a Department of Population at Harvard Medical School, we're actually trying to have them fund a study. So more and more of the entities coming to us are actually recognizing one of the benefits of this approach, and again, we're doing this now for the non-rare condition drugs, is that it actually generates very good real-world evidence, which then can be used going forward. And again, the other point here I'd make really importantly is this reduces uncertainty for the companies that are submitting their drugs for approval. So now there is the uncertainty will it get approved, but on top of that, there's the uncertainty will insurers cover it. And I'm seeing the frustration among the pharma companies where they're seeing the variance response. And even worse, I mean, really, it's about the patients. What the frustrating part to me is we're seeing frustration on the part of the patients who want treatments that are effective. They don't understand, and I don't blame them, why sometimes drugs are approved by the FDA, but they can't get them for themselves. So I think we need to do better if we're going to balance access and affordability and ensure innovation, and I'll look forward to the discussion. Thank you.
Andy, do you want to shoot a question, or do you want to?
Sorry about that. Yeah, we will take clarifying questions only at this point, the discussion more broadly. So if it's a clarifying question, by all means. And please introduce yourself.
Yeah, my name's Rory Collins from Oxford. It is a clarifying question, but I think it's one that's critical for there to be informed discussion through the next 2 days. And it relates to the statement on one of the slides that clinical trials do not equal RWE. And I think that that's a false statement. In the December 2016 paper by Rachel Sherman in the New England Journal and other authors here from the FDA, Melissa Robb, Rob Califf, Bob Temple, they explicitly state that is a false conclusion by saying, we believe that real-world evidence can be used across a wide spectrum of research, ranging from observational studies to studies that incorporate planned intervention. It's incorrect to contrast the term real-world evidence with the use of randomization. And I think if we don't understand that point, then we're going to have debate about completely different definitional issues. I think one can make the case for improved randomized trials and making them more pragmatic. But the idea that you can do away with randomization, I think, is a different point altogether. And I think unless we do have clarity as to what we are debating, then there's going to be confusion.
Sure. And again, I think I partially agree with that, but the point there was less about the study design and more when you take these kind of treatments out of the hands of someone who does nothing but see patients, for example, with that diagnosis for a living, and put them in a different setting, sometimes they're not used correctly. And we've seen that. We've seen cases with some of these drugs where we've said no to some of these, and I won't get into the details because of time, but in some, and again, not no because they, even because of the cost issue, because, for example, they didn't meet some of the basic labeling such as the genotypes or types of the disease that was approved for. So what you're ignoring with that statement is frequently a lot of that time the practitioners out in the community get it wrong, and what they're not doing is consistent with the study, regardless of how good the study is. The other thing, again, when back to randomization, et cetera, perhaps, but it doesn't change the fact that with some of these rare conditions or rare variants, it may be very difficult to create the kind of studies we'd like. So I would argue, so I would disagree, I guess, with your conclusion and maybe with the conclusion of that article, and we can have hopefully more of a dialogue over the next few days.
Rob, do you have a clarifying question?
I want to clarify Rory's clarification, just because I can see how this is so confusing for the audience. I don't want to get drawn into the argument about which is better and all that stuff, but just there was a problem that occurred in the drafting of the Cures Act that I think has really confused the world. And this is a true story. I thought we had it all right, and then the last 48 hours, the gang that wrote the final bill locked itself in a room and we had no access. And what came out was a statement that said real-world evidence is everything but randomized trials. But my understanding is we fixed that law now because that was never the intent. It doesn't mean that real-world evidence has to have randomization, but just so people know, I think a lot of people are reading the law saying, okay, that's what the FDA intended, that's the way it should be. But it's very clear now in the law that randomization can be a part of real-world evidence, and so it shouldn't be excluded.